Okay, so we're going to talk about the basic history, taking about the antenatal case. Antenatal case means the patient is pregnant till now. She has not delivered a baby. So what are the history that you're supposed to take? Before taking any history, you have to know that obviously you're supposed to take the consent, and then you have to verify the patient is the exact patient that you're supposed to take. You have to confirm by the age and by the name of the patient, right? Along with this, you have to take the basic patient history, relevant history. What I mean to say is that what is the name of the patient, where is the patient coming from, or what is the patient occupation, the age, the patient who is giving the history, and what is if the patient is giving history by himself or herself, or someone else is giving the history. You have to note the the details, who is giving, what is the relationship with the patient and that person who is giving the history, and the contact details of the patient, right? So all these things are basic, and then you're supposed to take the chief complaint. Now, what is the meaning of chief complaint? Is it's not that I'm having abdominal pain or I'm having vomiting or something. You have to know what is the meaning of chief complaint is. What is the cause? What is the cause that brought the patient to the hospital? Let's say I'm having abdominal pain for last 10 days, right? And I came to OPD today, or I came to emergency room today. Can you write I'm having abdominal pain since 10 days? No. If my abdominal pain was so severe, if it would have been so dangerous, why would I stay for 10 days? You have to ask the patient that why did you come to hospital today despite you having abdominal pain for last 10 days? Then the patient might say that yes, I was having abdominal pain for last 10 days, which was not very severe, but today in the morning it became very severe. I could not take anything, or I could not think of anything. It was hurting like crazy. So this is your chief complaint, acute abdominal pain since morning. Now when you write about the chief complaint and then you write about the HOPI, then you say yes, the patient was giving a history of abdominal pain for last 10 days with exaggerated today in the morning, and for which the patient was not able to do his daily activity, so the patient came to the emergency room. That is the meaning of chief complaint. Chief complaint is simple way you have to understand is why or what caused the patient to come to the hospital today. The main cause, right? Okay. So once we take the chief complaint, we come for the HOP, and then we take the main sequence-wise history for antenatal case. In first trimester, you have to you have to ask when did you lose, when did you have your amenorrhea? That means you're not having a cycles. Once you have missing of cycles, there can be many causes of this. Now you have to understand, was it an accidental pregnancy or a planned pregnancy? If it is an accidental pregnancy, yes, the outcome will be different. If it is a planned pregnancy, you won't be that much, worried that, okay, I missed my periods, because yes, you're planning for it, right? So first thing first, you will do a UPT, that is urinary pregnancy test. Okay, so anytime we are taking any history, we have to make sure that we're taking in the complete full form. Here I have written it in short form, but we're not supposed to write in short form. You have to write in full form. So now it's very important that you have to ask the patient that did you take your UPT at home or hospital, because sometimes I have seen patients who do not know how to do UPT. Right? It is a very simple process, but yes, you can encounter a variety of patients where they can misinterpret it, or the UPT kit might be damaged. There are two lines that you're supposed to see. There's one is known as test, one is known as control. Sometimes the kit might be damaged. If the control line is not there, you cannot use the test because it's invalid, because the control is damaged in the kit. So that is the reason you have to do the UPT in the hospital. Okay. Once you do the UPT in the hospital, then you have to ask the patient, did you take folic acid or not? Did you take folic acid prior to pregnancy? Because this is very, very, very important in order to reduce or prevent neural tube defects. Okay, very, very, very important. After this, you have to ask the patient, do you have any history of diabetes mellitus? This is very important, because if the patient is having diabetes mellitus before pregnancy, the diagnosis changes. And if the patient developed diabetes mellitus during the pregnancy, the diagnosis it again changes, right? Then you have to ask, are you having any history of hypertension? Very, very important. Or any serology positive. What I mean by serology positive is hepatitis B infection, hepatitis C infection, HIV 1-2 infection, because this can transmit to the doctor, to the nurse, or to the health assistant, or to the baby while doing certain examination, or the end stage when you are delivering the baby. Okay, when the uterus contract, that time some amount of blood from the maternal side can enter to the fetal side. So that's a dangerous thing. Okay, so that is the reason we need to know the serology condition of the patient. Along with this, we need to know about ectopic history, because one of the risk factor of ectopic pregnancy is itself a previous history of ectopic. So if I have ectopic pregnancy history, I can have ectopic pregnancy this time also, right? After this, you have to ask the patient that any USG is done or not. This USG in first trimester is done to see is the pregnancy in the uterus or outside the uterus. That is the reason of USG. And any milkish discharge is coming from the breast or not. Okay, this can come out in the first trimester also. Along with this, you have to ask the patient that how many ANs, this antenatal case, antenatal checkup have you done, and how many times you have you done, and what time have you done. Okay, this is very important, right? Along with this, you have to make sure that you have to ask what was the weight before the pregnancy and what is the weight right now, okay, in the first trimester, because you have to know what is the weight gain of the patient. If you do not know what is the pre-pregnancy weight, you cannot make sure what is the weight gain of the patient, right? And you have to ask, are you having increase in urgency of passing urine, or having increase in the frequency of passing urine? Because in first trimester the uterus is growing, and in the first trimester uterus is pelvic organ, so it is normal to press the urinary bladder, okay? And in second trimester the uterus becomes big, and then it becomes an abdominal organ. So if you are having issues with the urinary system in first trimester, it's not considered that dangerous, because obviously it's in a pelvic organ, so it's going to compress your urinary bladder, okay? Along with this, you have to ask, very very important, are you having nausea or vomiting, excessive nausea and vomiting? Because this is very very important. First time you are getting pregnant, this is primary gravidia, that's the first time you've experienced pregnancy in your lifetime, and in the first trimester before 12 weeks of gestation, you will be having nausea and vomiting. That is known as hyperemesis gravidum. This is very very not dangerous, but it can proceed to dangerous. So treatment is, you have to tell the patient, counsel the patient, don't eat anything that aggravates nausea, vomiting, or anything like that. And sometimes you need to give, dry biscuits, which helps to absorb the HCl, and eat. Keep on eating, and anti-vomiting drugs you have to give. Sometimes you have to maintain the hydration of the patient, because the patient is vomiting so much, and the HCl goes out. The body will become from all the acids are going out, so the patient will become metabolic alkalosis, right? So these are the things that you have to make sure that whenever the patient is vomiting too much, okay? Along with this, you have to understand, you have to ask the patient that, are you having any history of, blood transfusion? This is very important, because you can have cross-match reaction or any serology. Yes, obviously, this generally should not happen, but yes, you can get a lot of infection. The list can be so big that what are the infections that you can get from blood. Okay, blood transfusion, very very dangerous. And you have to ask any history of surgery or trauma, because if you are having a previous history of cesarean section, it is very 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 risky that you will want to do an vaginal delivery, because this incision that we give in the lower uterine segment, that incision is never strong. Any incision given in your body, or any cut that is made in your body by surgical cut, that cut will never be as strong as the normal structure. So when the uterus contracts, that incision line can rupture. It's a very dangerous thing. Okay, any history of trauma, obviously you don't want to have any trauma in the abdominal area, you don't want to follow, you don't want to something coming hitting your abdomen. Very 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 important. Along with this, you have to make sure that any history of drugs, very important, very very important. Are you taking any certain kind of drugs that can affect the baby? Obviously it can also be an alcohol, nicotine, or second-hand smoke, or are you taking anything, warfarin, okay, teratogenic drugs. It's very important. Any radiation exposure. What I mean by radiation exposure is mostly more of about your CT scan. It's very 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 harmful for the kid. Okay, CT scan, or you are having to a certain extent radiation exposure from chest X, so it's not that dangerous, but yes, it can be dangerous. But CT scan is one of the most detrimental. We don't want you to take CT scan during whenever you are pregnant. Okay, now coming to the second trimester, very very important. Whenever you come to second trimester, again you have to ask, did the amenorrhea continue or not? Because you can have a spontaneous abortion, or there can be leaking can be there, or they can miscarriage, anything can be there. So you have to always ask the amenorrhea was continued or not. Okay, once this thing is done, and you have to ask, was there any PV leak? If there is any PV leak, or there was any discharge coming out, or there was any blood coming out, bleeding might be coming out. Okay, this is very very important. And then you have to ask about the heaviness of breast, because the breast will slowly become big. Along with this, you have to ask progressive enlargement of the abdomen because the baby is growing. Oh my God, the cars. Okay, the progressive enlargement of the abdomen is very, very important because obviously the baby is growing, so the abdomen will grow in size. Weight gain, very important in second trimester. What is the weight gain of the patient? Very, very important. And the history of fever. Now, this is an important thing. Any history of fever or any exposure to pets like cat or something, because we're suspecting if the patient had any torch infection. Okay, we do not want you to have torch group of infection. That will be very, very dangerous, and this should be normal. Your frequency and urgency of urination should reduce. Okay, it should happen. If it does not reduce, then there is a pathology that you might be having infection, UTI. Okay, along with this, you have to ask the patient that did you take iron calciums or not, and also how many ANC visits were done and what time it was done. Anomaly scan was done or not. This is very, very, very important, that any genetic defect in the baby can be identified in second trimester. Okay, you can identify Down syndrome or like very gross anomaly. You can see the the thickness of back of the neck or the thickness of the nose. It helps you to identify neutral thickness and all this thing. That helps you to identify Down syndrome. Okay, and gross anomaly can be found out. Okay, along with this, in this we do something called as glucose challenge test, in which we give you glucose and we will tell you not to eat anything. We will do every hourly. We will test your blood sugar level. Okay, this is very, very important. That glucose challenge test is very, very, very important in second trimester. Along with this, obviously deworming tablets has to be done, because unfortunately most of the people in the developing and underdeveloping countries are having anemia. It's very, very common to see patients with anemia. Like 50% of the patient will be having anemia. Along with this, you have to, this is, and the point that I have highlighted here is very important, is that history of epigastric pain, headache or blurring of vision. This is absolutely very, 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 very important, because we are ruling out pre-eclampsia and eclampsia here. Okay, and you have to ask the patient that when was the first fetal movement that you felt. Okay, this is known as quickening. It happens in around 5th month. Okay, now coming to the third trimester, very important is third trimester. Again, amen continued or not, PV discharge. This is important. One of the most important thing here is this line, itching of palm and soles. Okay, the reason exactly we do not know why this happens, because this is known as mark my words, it's not obstruction. Okay, it's obstetric cholestasis. Obstetric cholestasis, it means we do not know, because of some hormonal changes, progesterone, estrogen, you're having cholestasis. That's why you will be having bile salts and pigment getting deposited in the nerve. So you will be nerve roots, so it will irritate and it will cause you itching of palm and soles. Okay, and again, US is done or not, very important. If done, at what time and how many times it was done. And again, history of this, obviously you have to see the weight gain and heaviness of breast. Okay, and again on everything you have to ask, did you get any trauma, or did you get any radiation exposure, or are you taking some kind of medication, or did you do any surgical intervention? Anything has to be mentioned in this third trimester as well. Now once this thing is done, you have to come about the drug history. Very, very important is that hypothyroidism. It's very, 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 very vital, because most of the female, like, it's why hypothyroidism is very, very common in females. Okay, so hypothyroidism, what happens is here is that if you're having hypothyroidism and you're not taking your drugs very, very carefully, okay, if you do not treat hypothyroidism, the baby that is being born by you will be having reduced amount of IQ. There will be the mental growth will not be adequate. They will be grossly reduced. Okay, it's very, very important for that reason. Along with this, yes, anti-tubercular drugs, very common in this area, and antiviral drugs, yes. Okay, if you are hepatitis B, hepatitis C, you HIV1, HIV2, if you're having this, yes, we need to know that are you taking the viral drugs or not, because we don't want these things to transfer to the baby, to the kid also. Along with this, are you taking any kind of teratogenic drugs, or you're taking some warfarin, or you're taking any aspirin? Yes, aspirin is controversial, but sometimes you need to talk to your doctor regarding aspirin, because sometimes low dose of aspirin should not cause any effect. But if you're taking high dose of aspirin, yes, whenever you're delivering the baby, you can go in postpartum hemorrhage. Okay, and any allergic history, very, very important. Are you allergic to any kind of antibiotics, or any allergic to any kind of food? Peanut, very, very important. Food and antibiotics, drugs is very, very important. Okay, thanks.